we will touch on the concept of time zero eligibility and treatment assignment in observational studies. Usually it's an alignment of these terms and time that will cause some bias in our studies. Then we will move on to understanding the problem of immortal time bias and how the consensual approach is able to address this. Then I will talk about briefly describe how the cloning, censoring, and the weighting work together in a consensual approach. So to start with, this is the stuff that is really trendy right now. It's what we call target trial emulation. By definition, we are going to apply the study design principles and the analytical approaches that we normally use for randomized trials to observational data with an aim to estimate a causal effect of an intervention. So there were a few common study approaches that were used in target trial emulation, namely the active comparator one. I believe many of you are quite familiar with this, and indeed this is the most commonly used approach as well. Then there were a few more different types of approaches, namely the sequential nested trial emulation and the today's main topic, consensus weight. Before we talk about the details of consensus weight, why do we need the target trial emulation? With obvious reason, it's that we would like to utilize the rich real-world data to address some of the clinical questions that may not be fully addressable in clinical trials. But then the use of real-world data has come with its limitation and challenges as well. And in many of the cases, there were bias in using real-world data for observational studies. And to get rid of the avoidable bias, that's where the target trial emulation framework came in. So in recent review by Bykov and colleagues, they look into the prevalence of avoidable bias in real-world studies that looking into medication safety and effectiveness. And to be honest, it's quite shocking that in this particular review, 57% of the included study will suffer from immortal time bias, and 44% of them were suffering from prevalent user bias, which are something that we would not like to have in our observation studies. So target trial emulation framework, it's a framework that we try to imagine a hypothetical clinical trial that could be used or conducted to answer our question of interest. But here we are talking about a causal question. So this such a imaginary or hypothetical trial is what we call the target trial. And by means of emulation, we are going to specify the protocol of this particular target trial, and we are going to emulate each of the component in this trial protocol with the observational data. So there were a few terms that we commonly touch on. It's the estimate, estimator, and estimates. So they are, well, they sound similar, but yet they are very different. So estimate is something that you would like to have. So that is what you want to see. In my example here is, let's say I'm craving for a beef Wellington. So the estimate is the very perfectly cooked beef Wellington that I wish to have. The estimator is the process on how you get there to what you are looking for. So in this beef Wellington example, it's the ingredients and also the cooking method. Everything together is my estimator. And eventually I got my estimate. So this is what I cooked last Christmas and this is what I have. So you can see that our size different from what I intended to have, my estimate, but then it looks like something eatable. So I'm happy with it. I could bear the bias that were in my estimates. So that's the basic concepts. But we first develop the causal question, and then we go through the eligibility criteria for our target trial. Then we define the treatment strategies and how are we going to do the assignment. So in trials, we have randomization. In observational data, what approaches that you're going to apply for your strategy assignment. After that, we talk about the follow-up time, how are we going to define the follow-up time, and how are we going to capture the outcomes with the observational data. Then we talk about the causal contrast, whether it's an ATE setting or an ATT setting, whatever. What is your target causal contrast? And then what will be the statistical approaches that you're going to apply in order to emulate your target trial? So that's a very typical role for a target trial emulation study. Of course, when we getting our hands dirty, there are a lot of operational definition that we have to consider when trying to emulate a target trial with observational data. But still, we first specify the target trial with the causal estimate, with identifying all the relevant assumptions into it, and what will be our estimator. Then we try to find what would be the best way to emulate such a trial with the observational data that we in hand. So that includes the data mapping on all the concepts or the conditions that will be involved. How are you going to identify your exposure and outcome of interests? What will be your observational analogs of your causal contrast, so on and so forth. And of course, confounding factors. How are you going to identify with the observational data in order to emulate the exchangeability and randomization. So these are all the key elements that you may have to go through when planning a target trial emulation study. Having said that, the key and perhaps the most important bit is to accurately emulate the designs of a randomized trial using observational data. So in that sense, if we are able to get as close to the randomized trial as possible, we will probably in a very safe place. So that's what we are aiming for. So what are the challenges in it? So in a randomized trial, there were three major components at randomization that will be happened. Number one is to assess the eligibility of the individuals. Number two is the treatment assignment. And number three is the sort of follow-up. So typically in a randomized trial, all these eligibility, treatment assignment, and the sort of follow-up time all happen at the same time. And typically we will have a washout period right before the randomization, just to make sure that everyone included were the new users. And then after the randomization, the individuals who were included in the trials will be allocated to either the exposed group or the comparator group or a placebo group accordingly. But then all these three time points happen all at once, usually. Assess the eligibility, assign the treatment, and then start to follow up. So that's fine if all of these three times were happen all at once. That should not be an issue. So we would like to have something similar in an observational studies, but then sometimes we do not have a placebo and we can't estimate a placebo with the observational data. So in some sense, we may have to change it to the unexposed group. And ideally, if we are able to align all these three components towards the same time, then this observational study, it's kind of like very similar to what we have in the randomized trials. In reality, many of the observational studies may not be able to align all these three components all at once. So if there is a misalignment of all these factors, let's say you have your treatment assignment before you start a follow-up, then you may be suffering from a prevalent user bias. If your treatment assignment is after you start the follow-up, then potentially you may be running into immortal time bias. And in many of the cases, especially when we are trying to compare treated versus non-treated group, all these bias may favor the treatment, the exposure of interest. So that will overstate in your results and potentially affect the conclusion, which is something that we would not like to have. So is there a method that could align all the eligibility assessment, the treatment assignment, and also the start of follow-up at the same time for real-world data. That comes along today's main dish, the consensus weights. So consensus weight is an approach that forces all the three components that all happen at the same time in order to prevent, number one, the prevalent user bias and also the immortal time bias. But it's more to do with the immortal time bias in that sense. So in the next couple of minutes, I'm going to talk about what is consensus weight and when and why we should use it and how we could use it. Consensus weight is very well named. So the entire approach is only involved with three key steps. Step number one, clone. So we create copies, what we call the clones, for each eligible patient at index, each representing a hypothetical treatment strategy assignment. So if you have two treatment arms, then you clone your entire cohort into two copies. If you have three, then you have three copies, so on and so forth. So no matter how many arms that you are going to have in your emulated trial, you have to replicate how many copies of your entire population. So that's step number one, clone. Step number two is censor. For each clone, we censor the follow-up when it deviates from the assigned treatment strategies. That is, the individual who is no longer adhere to the originally assigned treatment strategy, we will censor them. And step number three is weighting. And it's kind of like it's carried forward from step two, because the censoring in step two, it's a artificial censoring that could potentially induce selection bias. And that's why we will do the weighting afterwards to outweigh those who were still adhering to the assigned treatment strategy in order to minimize the selection bias accordingly. So that's in text, in context. What are the steps of consensus weight? And that's the very basic setting. Consensus weight basically just include these three main steps. How does that look like graphically? So imagine you have your original cohort that you have already sought out all the inclusion, exclusion criteria. You assess the eligibility for everybody. Then in this particular example, I have two treatment strategies, A and B. Then I clone the entire cohort into two copies. And in one copy, every single person were being assigned to treatment strategy A. And the other copies, I assign everybody to treatment strategy B. That's the clone. Then we move on to censoring. We censor those who did not adhere to the treatment allocation throughout the follow-up time. And after that, we build the censoring weight to outweigh those who were still in it. So the characteristics of cloning is that by doing the cloning, individuals' baseline characteristics are consistent, and indeed it should be identical across all treatment strategies. So the cloning steps, it's aimed to ensure the exchangeability at baseline. But then, because we are doing something else afterwards, so the exchangeability is only guaranteed at baseline. So that's cloning. Censoring. Artificial censoring occur when deviation from the assigned treatment strategies. So each clone is forced to adhere to its treatment assignment during the follow-up time. And because this censoring is non-random, as I mentioned, that could induce selection bias. And that come along the weighting bits, we try to outweigh those who the censoring comes with the similar characteristics in order to minimize their selection bias accordingly. That still sounds very abstract, right? So in this recently published paper, Gabber and colleagues, they did an excellent job in illustrating this consensus weight method with a patient timeline. And I'm trying to emulate its changing it a little bit and try to illustrate the consensus weight approach and how it works in a very simple sense. So imagine I have 5 patients These 5 patients were diagnosed by something at time 0, so they all share the same diagnosis at time 0. And according to the treatment guideline, they are supposed to receive the treatment within the 180 days after diagnosis. So in this setting, I have 5 patients, and these were what happened to them after 1.5 years. So within the 180 days, patient number 1 died at day 30. Patient number 3 received the treatment at day 45, but just one patient received the treatment within the 180 days. And for the rest of the patients, there were nothing happen on patient number 2, but we do have a complete follow-up until 1.5 years. Patient number 4 died at day 210, and patient number 5 received the treatment at day 225. So imagine I have 5 patients here, and I would like to evaluate the effectiveness of the treatment on the mortality risks. So these are the patients that I have. So I'm going to apply the consensus weight in these 5 patients. Then I do the first step, cloning. So I simply replicate all the 5 patients with identically the same setting. And the orange bar indicates treatment strategy A. That means it's treatment at the previous slides. And the red bar is representing no treatment. So I just simply replicate these 5 patients into 2 copies. And what happened to them are identical at this particular stage. So that's the cloning bits. After I have cloned them, then I'm going to censor them according to the assigned treatment strategies. So patient number 1 died at day 30 before receiving anything and before passing the 180-day treatment first 4 days. So nothing happened to them. Both the copies of patient number 1 were died at day 30, and then we keep it as it is. For patient number 2, there were 2 treatment strategies. For the treated bar, that means the orange bar, we do not receive the treatment at 180 days. So we censor this particular clone because it did not adhere with the treatment assignment. And then for the non-treated bar for patient number 2, that's fine because it's non-treated, then we could keep on follow-up until the end of the study period. So that's patient number 2. For patient number 3, this particular individual received the treatment at day 45 and died on day 240. So for the treated arm of patient number 3, that's fine. We could continue to follow up it towards the end. That means the date of death of these individuals. But just because patient number 3 received the treatment at day 45, so we have to censor the non-treated clone at day 45. So that's the C for patient number 3. Patient number 4 did not receive any treatment throughout the entire follow-up. So similar to patient number 2, we censor the treatment clone of patient number 4 at day 180. And we continue to follow up until patient number 4 dies for the non-treated arm. So that we will have the follow-up until 210 days, until patient number 4 dies. For patient number 5, patient number 5 did not receive treatment within 180 days. So for the treatment arm, it's still the same. We censored it at day 180. Although patient number 5 received the treatment after day 180, the original treatment assignment is that you have to receive the treatment within 180 days. So in that sense, we treat patient number 5 clones as untreated for the untreated arm, and we continue the follow-up until the end of the study period. So that's the censoring for these 5 individuals and their corresponding clones. So I have done the censoring, the next bit is to do the weighting. So how to calculate the weights? Let's have a look on the clones that were being assigned to the untreated arm. So at this particular point, that only one censoring occurred. Patient number 3 were being censored at this particular point. At this point, we only have 4 individuals were still in our study group because patient number 1 died at day 30. So here we have 4 people, and then 3 of them are here to the treatment assignment. So the probability of an individual who are adhering to the treatment assignment is 0.75. And with this probability, we do the inverse probability weighting for those who were adhering to the treatment allocation. So the weight for the clones on patient number 2, patient number 4, and patient number 5 is 1.33. So it's just the reciprocal of 0.75. So we have done the non-treated arm. Then how about the treatment arm? So at day 180, we have 3 people who are being censored. We only have 1 people left in the follow-up. So in that sense, the probability of adhering to the treatment assignment is 0.25 because 1 out of 4 is adhering. And with this, we could calculate the inverse probability weighting for patient number 3 here is 4. So this patient number 3 will be upweighted by 4 and eventually in our calculation. So that's the weighting bit. And that's pretty much the concepts on how we are going to apply clone sensor rate in a typical studies. So how does that look like in terms of a data set? So this is our original patient timeline thing for the 5 patients who were included in our study. Originally, we should have a data set something similar like this. We have the individual 1 to 5. We have only 1 individual who received the treatment within 180 days. Patient number 3 received the treatment at day 45. And then we have the outcome status. 3 of them died at various time points, and 2 of them were censored towards the end of the study periods. And then we have the different follow-up time accordingly for these 5 individuals. So that is the basics. After we apply the clone sensor weight, the data set will become something like this. So patient number 1 is straightforward because patient number 1 died at day 30. So for both of the patient number 1 clones, no matter it was allocated to treatment arm or non-treatment arm, it's the same. Patient number 1 were being censored at day 30. And then we do the same for the rest of the patients. For the individual who do not receive the treatment, we see in within the 180 days and were being assigned to the treatment arm, they are being censored at the 180 days. So patient number 2 were censored at day 180 for the treatment arm clone. That's the same for patient number 4 and patient number 5. Patient number 3 received the treatment throughout. So at day 180, it received the weighting, upweighted by 4 as we calculated before. So we continue to follow up until the end of the study period or death with the upweighting here. So patient number 3, starting from day 181 up to it died, it received the weighting of 4. So we do the same for the non-treated arm as well with all these 5 patients. So there were only 3 patients received the upweighting of 1.33 at day 46 when patient number 2 were being censored. So it's the basic data sets of the clone sensor rate. So with these data sets, then you could simply fit in a time to event model for the analysis. And that is how it looked like typically. So what are the potential limitations of the consensory approach? The first bit is the eligibility could only be met once naively, because we try to force the eligibility time, the treatment assignment time, and also the start of follow-up to the same day. So naively, it could only happen once. And in some cases, a clinically reasonable grace period has to be chosen. So in my previous example, there is a grace period of 180. According to the treatment guideline, the patient should receive the treatment within 180 days. So that is the grace period in my previous example. But sometimes it's hard to choose when clinical guidelines were not that clear, or it's kind of arbitrary on when the treatment should be assigned to the patients. So that could bring some challenges when applying the consensus weights. The third bit is inverse probability weighting is used for the censoring weight. So typically it's just an ATE for causal contrast, because for the nature of the inverse probability weighting. And of course, we mentioned that we try to emulate a target file, but then binding and placebo are not available in real-world data. There's almost no way for us to emulate the blinding and also the placebo with observational data. Consensus weight could sort out some of the time-related bias, typically the immortal time bias, but confoundings could still exist, as randomization could only be emulated through statistical approaches. So in some of the cases, there were still residual confoundings, and we still need to spend efforts to tackle confoundings on top of the consensus rate that were being applied. So that's the basics. Let's move on to one example that I had used the consensus rating approach in studying the effect of beta blocker on mortality and cardiovascular outcomes among patients with obstructive sleep apnea. So this study, we try to emulate a trial. So we first define a specific target trial accordingly. So we want to include new onset individuals with obstructive sleep apnea without using beta blocker as our base cohort. So that is our eligibility criteria. For treatment strategies, it's a very simple treated versus non-treated setting. So the treatment group is the beta blocker group, and then we have a non-exposed group for those who does not have beta blocker. Treatment assignment in a target trial, it's randomly assigned it, and they will be aware, because there is no blinding, so individuals and their treating physicians may be aware of the assigned treatment strategies. So that's our target trial. For the outcomes are CVD and all-cause mortality. Then we try to emulate it with the observational data. We could fit in the same eligibility criteria, if we are able to identify new onset sleep apnea in the data source. And we have to do the screening out process with those who were already on beta blocker before they receive the diagnosis of sleep apnea. For treatment strategy is kind of similar. We just simply to identify the prescription record on beta blockers. And for those who does not have the prescription beta blockers, we simply assume they were not using beta blocker accordingly. And then randomization is emulated through cloning the individuals with the consensus approach, and with assigning each replicate to the treatment strategies. And the way in identifying outcome is the same. We identify the cardiovascular disease and mortality event in the observational data. So that's the first 4 elements. So in our target trial, we define a follow-up at the start of the treatment assignment, and then until the end of the occurrence of the treatment outcome, transfer out of practice, that means dropping off, or the end of the study period, whichever comes first. And we should be able to emulate it with our observational data accordingly. Causal contrast, typically it's an intention to treat and per protocol approach in a target trial. But in our observational data, we use the observational analog for a per protocol effects. For statistical analysis, and in a target trial, it's the ITT and the protocol analysis. And individuals were censored if they deviate from their treatment strategies. So that's exactly the same with what we are doing. So we're going to emulate it with the per protocol analysis. So that's our target trial, and how are we going to emulate it with our observation data? So this is our patient inclusion flow charts, and that's slightly different from a typical cohort setting. Especially at this stage, we are doing the cloning. So we still apply our inclusion and exclusion criteria as if in a normal cohort study. But then after we have sought out all the eligibility criteria, we do the cloning. And by definition, that has to be the same individuals. We replicate it into two pieces accordingly. And then we move on to the analysis. And the cloning plate, we assigned it 2 copies. 1 copy is to the beta blocker group, the other copy is to no beta blocker group. And we applied the censoring on whether or not the assigned treatment strategy were being adhered with a grace period of 12 months. And then we applied the time varying inverse probability weighting conditional on the baseline covariates with a pooled logistic regression and truncated at the 99.5 percentile for the weighting. And we built the outcome model with a weighted pooled logistic regression with the censoring weights, including an indicator of the treatment strategy, the time, with its linear and quadratic terms, and the interaction of the time and the treatment strategy term, so as to ensure the proportionality thing for the survival model. And we also adjust for the inverse probability weights and all measure baseline covariates to sort of like do a doubly robust estimates in our output model. So we estimate a 5-year absolute risk, the risk differences between the 2 treatment strategies, the risk ratios with a point-wise 95% confidence interval using non-parametric bootstrapping for 300 samples. So that is our result. It's relatively not important, but then we identified our result a little bit weird. So we find an increased risks of beta blocker use among individuals with sleep apnea, with roughly about 35% increase in composite cardiovascular outcomes. We do not see an increased risk, at least a significant increased risk for the all-cause mortality. But it's kind of tricky. We are having a hazard ratio of 1.21. So that leads to some discussion in our study, but this is the result that we have. So this is the first study that I applied the clone sensory approach in a research question. So after it's published, I do a little bit of reflection there. And then there were a few points I think it's worthwhile to note. Number one, it's residual confoundings. The clone sensory approach is very helpful in get rid of the immortal time so that you could focus your effort in get rid of or minimizing confoundings. But sometimes you're still limited by what were being measured and what were the approaches that you're going to apply. And in some sense, negative control may be useful in synthesizing the impact on residual confoundings. So potentially you may also want to plan a negative control analysis, even if you're applying a clone sensory approach. The second bit is question that I ask myself is clone sensory the best approach for this particular question? Potentially a sequential nested trial may be a better alternative, just because the fact that beta blocker is not really indicated for sleep apnea. And in order to apply the clone sensory, we need to implement a relatively long grace period in it. And that may be concerning in some sense. And yeah, because it's kind of difficult to set up a reasonable grace period since my exposure is not really indicated for my cohort of interest. So potentially a sequential nested trial may be a better option. And of course, there was some database limitation. I used the GP database in the UK and without linkages to hospital records. So, but then my outcomes were cardiovascular diseases and mortality. So that will be better captured in hospital linkage or with the death registry. So potentially there may be some database limitations that were being suffered by my study, but that's kind of outside the application of the consensus array. So I have a little flow chart here for you to think about whether or not a consensus array approach is appropriate for your causal question. To start with, the first question that you have to ask is, can your causal question be answered by a randomized trial? If yes, then go ahead to think about it. If not, then this is not a valid question for a trial emulation. If that is the case, are you going to compare dynamic treatment strategies, or are you going to compare time-related treatment strategies? If yes, then consensus array will be very helpful. If no, then are active comparators available, or it's something that you may be able to implement? If yes, then you could simply use the active comparator setting. If no, then the next question is, will the eligibility criteria recurrently being met? If no, then you could use a sequential nested trial because eligibility could be met more than once. If yes, then you may want to think about whether the treatment strategy is initiated shortly after your study indexing. If yes, then you could go ahead to a consensus array approach. If no, then as I said, you may consider to revise your eligibility criteria and perhaps a sequential nested trial may be a better option. And towards the end is the average treatment effect of interest, because sometimes regulators may be more interested in the ATT rather than ATE. And unfortunately, naively, consensus array could only do the ATE approach. So if ATT is with interest, then you may need to think of something else. So that's come to the end of my talk, and I will be very happy to take any questions. Thank you very much.
Thank you for this insightful talk, Dr. Mann. We received quite a few questions in the chat. I don't know if we'll get through all of them, but you know, some of these questions are relevant to the examples that you've provided. Some are fundamental questions, and some more additional questions related to the application of clone sensor weighting. So with respect to your example on where you used, you applied CCW in your example for OSA, could you elaborate on your decision for arriving to 180 days for the grace period and considerations that we should keep in mind?
It's kind of arbitrary, and indeed we do the sensitivity analysis with the grace period because it's arbitrary. So switching it to a shorter time or even a longer time just to see whether there is an impact. And it's hard to, because the drug is not really indicated for the conditions. So we may have to come up with something ourselves. So at the time when we put the grace period, we think, okay, it may be a slightly long grace period. Then we subsequently do a sensitivity analysis with a different length just to see whether that impact the whole thing. Sometimes it may, and after I have done this one, I believe a sequential trial may be an easier option because it's free from this arbitrary setting.
Okay. The next question, in your example of the, in your beta blocker study, actually, when did you specify the target trial protocol, and how much inspection into the observational data did you do to generate the protocol?
So there were a few things, right? And the trial protocol should be set up at the first place. And then whether or not you're able to emulate it with a observational data, that it's a mixed bag of your expertise in available data sources. And how are you going to sort of like making use of the data to emulate your target trial? So that comes in pairs. But then the trial protocol should come first. Once you have your causal question, you could go straight in defining if it is a randomized trial, how would the setting should be. And once you have your target trial, then you try to emulate it with the available data. So that can be in pairs, sort of.
Okay, so there are another question. There are additional reasons for censoring other than deviation from the assigned treatment strategy. So for example, while treatment is used and censor at treatment discontinuation. So are the weights for censoring applied in the same way as they are for the treatment strategy deviation?
That's an interesting one. And you can see that I didn't add the censoring weight for the person that died in my example, because both arms suffer the same censoring conditions. And because they were being replicated identically. So that censoring event will not induce selection bias. And that's the reason why I didn't put the censoring weight for the death case in my example. This one. So patient number one died, and because they died, it will be censored at that time. And we didn't build the weights accordingly. So that could apply to other censoring events. If the censoring event will be occurred in both of the copies, then perhaps it may not affect the selection bias. But then if the censoring event will only occur for one of the cloned copies, then potentially you could build a censoring weight accordingly. But then the weight of setting up the weighting, it could be quite flexible. So if you have other stuff that you would like to be weighted, you could also add another weight to the entire estimation.
Okay, so this is a more fundamental question, and there are a couple similar questions. I mean, a couple people have asked a similar question, but could you please elaborate and clarify what you mean by time zero?
Time zero usually is the start of follow-up time. That means we start to observe our outcome of interest after that date. So by means of time zero, that sometimes we call it index date, sometimes we call it start of follow-up. The time zero is literally the first or the anchoring point of your follow-up time. Everything starts here.
Okay, thanks. So Miguel Hernan had suggested that G computation could be an alternative to clone sensor weighting. So what are your thoughts on this? It seems G computation cannot be applied naively in the presence of immortal time bias.
Yes and no, but then they are not, well, you could use both together technically, especially after the grace periods in your consensory setting. And G computation, well, if I put it in a very naive way, originally it was being built to tackle mainly for time varying factors or time varying confounders. And in that sense, we could also incorporate at least the G formula into a consensory setting. They are not mutually exclusive. You could use that all at once. Or even you could put it like a module structural model thing towards the follow-up time. It could, yeah, it is also possible. So they are all usable and sometimes could be used at the same time. But you just need to um, be sure of what's your causal question and what will be the best way to tackle your causal questions. So sometimes consensus may be easier, especially if you have multiple treatment arms. If you have more than three, then it will be quite challenging to use conditional methods or even in G computations.
Okay, and here's a question about additional application of the closed sensor weighting approach, but is it better suited to either interaction modeling or stratified analyses with stabilized weights as ways to examine heterogeneity, and why?
It depends. And I don't think there is a one-size-fits-all solution for all these. And depending on the disease nature, the process of the thing, and also your causal back to your causal question. Sometimes stratified analysis may be an easier way out, sometimes that may not. And yeah, there's no one size fits all thing. So consensus is just an approach that you could easily fix the three components at the same time to get rid of immortal time bias. But other factors still in play in planning an observational study. So we still need to be mindful of other stuff as well.
And some more, I guess, yeah, hypothetical question, but yeah, what is the best way to understand how, the findings of your study would have looked without applying this clone sensor weighting method? So, how can we estimate the directional effect of bias on the endpoints without this approach, and thus understand how clone sensor weighting may have changed, um, affected the findings versus the same study without applying the approach?
Um, so I'm not sure if I get this question completely. So I take it that's, are there any alternative approaches that you can apply just to see how much bias a Glucose sensor could take care of, if that makes sense? Um, if it's a solely on immortal time bias from that aspect, there are alternative technique that you could also apply to minimize the impact of immortal time bias, namely the landmark approach. But the landmark approach is subject to conditional on the landmark dates. So in some sense, it may not be an ideal situation in some of the research questions. Alternatively, some people may use the time-dependent modeling technique to get around with the immortal time, but also subject to different limitation as well. So um, if you have a causal question and you like to understand whether consensus rate could help you to minimize bias, I find it difficult because you have to plan the study in the best way to minimize all the relevant biases. And consensus rate is just one alternative of everything. That may not be the best way. And yeah, it's hard to tell you.
Hmm. Um, so another question. There are a lot of questions. I'm really impressed with the level of engagement from the audience today. So I don't take credit for any of these questions, but one is this question is specifically from your example. So regarding the first day of follow-up in the clone sensor weighting approach when using admission as time zero. So, many important variables are only measured at the hospital, and thus calculations for the probability of treatment can only be accurately estimated after admission. And so, with no possibility of sorting temporal events with greater accuracy than 1 day, then how do you actually handle day one? And if you clone patients, at time zero, you cannot accurately weight patients on the first day of the trial due to missingness of important variables. So would you not then clone patients who received treatment on day one, since the data granularity is only available, on the scale of days?
Um, so there were several things here. Number one is is your proposed time zero the best time zero? And that usually come together with when you would like to start your of your follow-up time. And even if I put it in a real clinical trial context, we sometimes we may need to have a sort of like recruitment window for patient to come in, and that may take some time. But then relative to the same patient, they all have their treatment assignment, their follow-up time, and also their eligibility sorted in the same day. I guess that is the key. And there are limitations in some of the data. And if we want to get rid of the limitation, then perhaps you need to understand the data best. Find someone who understands your data best and to see whether that will be the best way to tackle your question. This is slightly beyond the consensory approach. It's more to do with your data sources.
Okay. The next question is, how does the clone sensor weighting method apply with how does it take competing risks into account? So, what would happen to patients who encounter the competing event? So, with censoring
It
this
did not.
patient.
It did not. Consensory naively did not take care of competing risks. So you still need to apply whatever approach that you may want to in tackling competing risk issues.
Mhm. And as you mentioned in your example, there still might be unmeasured confounding. So negative control outcomes could be one way to analyze this, of course, but then there's also the standardized mean difference. However, this approach is not always presented or analyzed in papers that apply clone sensor weighting. So do you have any thoughts regarding using the standardized mean difference in studies with clone sensor weighting?
I am assuming you are mentioning those studies who use the stabilized weights in the consensus weights, and because they also put the parameter into the model. So technically, even if the weighting ending up to a slightly imbalance, they take care of it on the outcome model. So the imbalance was still addressed on the other side of the confounding triangle. And I'm not sure whether that is the reason why people prefer not to report. But then, yeah, it's more to do with the confounding side, and we 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 could still apply our knowledge in tackling confounding same issues.
Okay, thanks. Um, we weren't able to get through all of the questions. There were so many, but we only have a couple minutes left, and uh, I wanted to bring up this question that's just more about the practical implementation of this approach. So, in your experience, what are the most common pitfalls or misunderstandings that researchers face when they want to implement the clone sensor weighting method for the first time?
I guess the entire setting is not really a straightforward one. So sometimes you may need to think carefully in order to get your head clear on what you are trying to do here. And throughout the weighting bit, that means how you set up your consensus weighting. And sometimes um, may be confused with the timing, what time I should use it as my time unit, Is it easier to use a total logistic setting that I truncate the entire follow-up into the same pieces, or we just treat it as a simple time to event model? And yeah, that could be confusing sometimes. And then what I did today is trying to do the most fundamental thing. So it's the origin of how it looks like. I also find it challenging to understand consensory by reading up the papers that applied this method, because there are a lot of different things also being applied on top of the consensory approach in many of the studies that use consensory. So that makes it slightly challenging especially for beginners to learn. So you may want to think carefully on what the best setting that could fit you, and yeah, try to think about it. What today would be the best way to use consensually.
And I might have to cut you short now because I think we're running out of time. But I would
Yeah,
just like to give thanks to you for this fantastic presentation on this topic of consensor weighting, and really to all of you for attending and engaging with your questions. We hope to see you all at the next ISPE webinar.